This is an example of some of the resources that are available for you up on Moodle for math. I would plan on math being a paper test and not an exam soft test. Just because it's easier, because I'm not here to be tech support and with exam soft, okay? I will give you a calculator, yes. It's those blue, like you can't store anything, so, okay. The other thing I will tell you is that you'll take the math competency and then I'll probably give it back to you, and so you won't know your result on Wednesday because I probably will not be driving to campus to grade, so I'll get them on Thursday and hopefully either have them Thursday or Friday for you, okay? But I think if you look at the questions, it'll give you an idea of the wording, so you can see like there's a heparin drip and there's a weight-based calculation. And so that's all under here. This document, I guess, confuses students because what happens is it kind of gives you an idea of what type of problem to expect. But I've had students who thought that they had to know every single type of problem on here. And that just shows you what type of questions will be on, and like the rules about joint commission. So for example, you did the math correctly, but you documented 0.5 instead of 0.5, that would be marked wrong. Okay, if it says round to the nearest tenth, so for example, you come up with an answer of 1.99999, and it says round to the nearest tenth, you're gonna answer 2, you would not answer 2.0. That's incorrect from a joint commission safety perspective, okay? So again, this is incorrect, this is correct. Okay. I try to make the math tests where you only have to put the numerals in, so you don't have to put the unit of measurement. So it'll tell you whether it's ounces, teaspoons, no pints or quarts or drams or anything like that. What I would go with for a cup is 8 ounces, which is 240 milliliters. I'm not real particular about the 2.5 or 2.54 for centimeters to inches. I don't know. What other questions do you have about math? All right. Onward and forward. So did you all in previous classes get test blueprints? You all know what that is? My test blueprints are not, I don't know, they're not anything fancy. Usually what I do is I try to say how many questions from each chapter or PowerPoint. So again, you'll notice that there's some sections that we have a lot of PowerPoint, so it's fewer questions per PowerPoint. So I would think of it more in days of lecture. And so kind of thinking about how many lecture days do I have? So if I have 5 lecture days before the test, there's going to be about 10 questions from each day of lecture. Morgan, could you do me a favor and just catch that door for me? Thank you. For the test. The other thing I would do is look at the objectives. So I try to have objectives at the front of every PowerPoint, and that will kind of guide you into things that you want to prioritize. Okay? So today we're just going to review, and this is very superficial, anatomical features of the female and male reproductive system. There we go. Most of that you're pretty solid with. The thing that you might be a little bit hazy on is the reproductive cycle and the menstrual cycle and hormones that are associated with that. So So I do feel like for many of you, that's the part that I would emphasize. So again, looking at the menstrual cycle and the hormones that fluctuate as part of the menstrual cycle. This particular section, we're going to talk a little bit about ovulation. You have to have ovulation to get pregnant. So in looking at female genitalia, we're looking at the external genitalia. Again, you want to bear in mind that we have the urethral opening is located above the vaginal opening, and so that's one of the reasons why whenever you put a catheter in somebody and you don't get urine, we leave the catheter in place because it's probably in the vagina. If you take it out, you're just going to put the catheter in the wrong place again. If you leave the first catheter in place, you know to go a little bit higher than that. But I will say some people then try to catheterize the clitoris, and you can't catheterize the clitoris. Okay, there's not an opening there. The vaginal opening is much larger than the urethral opening. Very high likelihood that you will put a catheter in a patient during OB, and it's because a lot of our patients have anesthesia, so they don't feel it, okay? Some of our facilities, we put catheters in pretty much everybody, and then we take them out when you have the baby, and then we put a catheter right back in right after you have the baby. There's some pros and cons to that. But one of the other structures that's critical here for us in terms of pregnancy is the perineum. And so when we talk about the perineum, it's the area between the vagina and the rectum. And so depending on how that is torn or cut, we'll refer to a laceration or things in childbirth. But generally what happens in pregnancy, it's a very vascular, it can become swollen, engorged, but for again, as you get closer and closer to having a baby, a lot more pressure here on the rectum. And looking at the side view, you can kind of see this is the uterus. And notice this term fundus. You definitely want to be familiar with that term. It's the top of the uterus. When we palpate contractions, we palpate them at the fundus. After you have a baby, we massage the fundus. It causes the contraction of the uterus to help slow down bleeding. Now, in a non-pregnant woman, you really should not feel the fundus of a uterus, okay? It's below the pubic bone. But you can see if you had a little human being growing in here, it's putting a lot of pressure here on the bladder, it's putting pressure on the rectum, and so that contributes to symptoms like urinary frequency, constipation, decreased GI motility, okay? Now, if I'm taking care of a pregnant woman and she's in labor and she says, I feel like I need to go poop, it's probably not poop, it's probably the baby. I would not say, oh, let me help you to the bathroom. I probably would do a vaginal exam to see how close the baby is because she may be crowning and ready to have a baby, okay? But again, what can happen is an episiotomy is where the healthcare provider will cut between the vagina and the rectum. A laceration can tear. We're doing a lot of different things now. We used to do a lot of repair with stitches, and we see less of that now, particularly for our superficial tears. But you have to remember that women can tear down towards the rectum. They can also tear up towards the urethral opening. So if you tear up or have a laceration that goes up to the urethral opening, it's going to be very painful every time you urinate because it's acidic and you're putting acid on an open wound, okay? But certainly, just looking at the external genitalia, a lot of times you have no idea that a woman might have some structural problems with her anatomy. And so again, we're looking at some women have a septum in their uterus. Some women can actually have 2 uteri, okay, and have, you don't know if there's a problem with an ovary or a fallopian tube just looking externally. And so for us as baccalaureate prepared nurses, a lot of times we're just kind of looking at the external genitalia just to kind of see if we see any abnormalities there. So you may be caring for women from a different culture that may have had female genital mutilation or female circumcision. And so again, the genitals will look different. For those women, sometimes there's no problems with childbirth. For other women, it can be very painful and very uncomfortable for them. Okay. So again, starting from the outside, we start with the vagina, then you go into the neck of the cervix. From the cervix, you go into the uterus, okay? So this is where it's kind of like the baby's apartment. That's where the baby lives and grows and matures. You have the fallopian tube, and then on each side, and then you have an ovary. So the ovary releases an ovum, okay? typically fertilization occurs in the outer middle third of the fallopian tube. So fertilization does not occur in the uterus. It occurs in the fallopian tube. But we don't want that fertilized egg, fertilized ovum, that little zygote, to stay put, because if it stays put, it becomes an ectopic pregnancy. So what happens is that these little flagellae, they kind of keep moving. There's prostaglandins there that help that fertilized ovum progress, and eventually what will happen is it will embed itself in the uterine lining inside the uterus. Now, we're talking about female reproductive system, so in a woman who is not pregnant, what happens is she releases an ovum. There's no fertilization, so that little egg, it just disintegrates. Okay? So when a woman has her period, she's not shedding the egg, she's shedding the uterine lining. And so some women have very heavy periods. It's because they have a very thick, rich uterine lining that actually is very good for pregnancy. Okay? But when you're not pregnant and you have that very, very heavy bleeding, it's very uncomfortable. You pass a lot of clots, and then they come and see you in the ER because they've passed out at Target because they bled so much and their hemoglobin is like 8. Okay? Now, you can release an egg from the right side, you can release an egg from the left side, you can release an egg from both sides. That's how sometimes we get twins. Okay? The other thing about this particular diagram or structure, there's a lot of ligaments that support the uterus. The uterus is a muscle. It has a lot of muscular fibers. And so the first time you see a C-section, what will happen is the uterus will come and it is enlarged, and they cut into it, and they're cutting into that muscle, okay? And then we need that muscle to contract, but it's pretty amazing to see how this, again, this organ just absolutely stretches out. You can see it needs tremendous amount of force to cause contractions to deliver the baby, but again, cutting into that. When you think C-sections are not a big deal, once you've seen that, you will understand why women have so much pain related to C-section. It is a big deal. It is major abdominal surgery, okay? Some women have a shortened cervix. Again, you don't know that. You might have a shortened cervix and never know it. What puts you at risk for shortened cervix? It's things like you had a lot of biopsies of your cervix for maybe HPV, cervical cancer screenings, and so that's why we don't generally like to do a lot of biopsies of young women, because if you have a shortened cervical length, it puts you at high risk for preterm delivery. Preterm delivery has lifelong implications for that baby, okay? So again, as part of pre-pregnancy planning, we certainly would want, as a well woman, to have well women visits. Again, have my exam, see if there's anything abnormal noted on exam. Generally, a BSN prepared nurse does not do this. It's a nurse practitioner, it's a physician, it's a midwife. We do have midwives at some of our facilities, so you may encounter a midwife at your clinical. They've actually just opened a birth center across I'm a Hoosier, they just opened a birth center across the river over in Clarksville. So I do think you're seeing a movement here with midwifery. And it's very interesting because where I used to work before in Indianapolis, I was with a bunch of midwives, so it's a regional thing. A lot of places really love midwives, but it's been kind of slow here in Louisville. But I do think you might get the opportunity to see a midwife at your institution. Now, in terms of anatomy, and taking care of women who are having a baby or wanting to have a baby, this happens to be one of the things that you really cannot change, and it's your bones, okay? So you're kind of stuck with the bones you have. Now, if you think about this, this is not a true test-shaped pelvis. This is probably like a 12-year-old pelvis, okay? It's for demonstration purposes. But in terms of the bones, we sometimes talk about women and we talk about the width of their hips, okay? But again, that's actually not the area that we need to be concerned about for the baby to come through, because what we're really most concerned about is down here in the true pelvis, and the baby actually needs to come through the outlet here. So I can't just look at somebody. You have to remember, I have family from Kentucky. She's got them birthin' hips. I don't know if you've ever heard that saying. It's like you can tell by the way she's shaped, if she has a big hourglass, that, oh, she'll be fine, she'll have a baby vaginally. But again, it's not the width here that determines the issue. It's more the width here. And the other thing is, some women have a prominent coccyx. So if you've ever fallen and hit your tailbone, that's what you've hit. And again, if that is prominent and you have very sharp ischial spines, you've then made this very small outlet for the baby to progress through. And so that's why some women have a hard time with vaginal delivery. There's nothing they did wrong. It's just the shape of their pelvis. Okay? Again, that can be assessed on exam. We can also do x-ray if we're really concerned. I do not see a lot of women getting pelvic x-rays to look at the shape of the pelvis. Usually it's with their well women visit, and then the provider will say something like, oh, you have a narrow outlet, or you have a very prominent ischial spine, something like that. So again, talking about the false pelvis and the true pelvis. And so this particular landmark, the ischial spines, it is super important to us because for childbirth, that's what we use for station. Station is a landmark that tells us that where the baby is in relation to mom's pelvis. So if I'm at a negative number, the baby's head is above the ischial spines. If I'm at a positive number, the baby's head is below the ischial spines. And so you'll talk about that tomorrow. So here are some examples of different shapes of pelvi. Most women have a gynecoid pelvis, okay? But you can see how the shape can be slightly different. Now, again, it's not saying if you have a anthropoid pelvis that you will definitely be a C-section, but there may be some complications in terms of how the baby progresses and gets in position. Babies, when they deliver, they actually should come out kind of face down, but some babies come out face up. And it may be just because they weren't able to rotate into the right location because of the shape of mom's pelvis. The other thing is, when we look at the shape of mom's pelvis, if it's very small or narrow and you have, let's say, a large baby, maybe you have gestational diabetes, maybe you're LGA, which means large for gestational age, again, that's a mom who's more at risk of having a C-section for delivery. So again, this is genetics. It's kind of you're born with what you're born with, but most women have a gynecoid pelvis, okay? Now the other thing we will mention is the diagonal conjugate, okay? So if you're looking in your prenatal records, they'll talk about the diagonal conjugate, which is determined on exam by the healthcare provider. And so when the healthcare provider does an exam, they'll put their fingers in, okay? And so what they're doing is they're kind of measuring from right underneath the symphysis pubis back towards the sacrum. So they're using their fingers to estimate, okay? Generally, we want that diagonal conjugate to be around 12.5, okay? But that's actually not the most narrow measurement that the baby has to come through. It's called the obstetrical conjugate. The obstetrical conjugate is estimated. It's estimated. And so we usually subtract about 1.5 centimeters from that, okay? The numbers are not the issue. What's the need to know? The need to know is if you see documented on your patient's chart the diagonal conjugate was not reached, okay? What that means is the diagonal conjugate was longer than the examiner's fingers. Is that a good thing or a bad thing? I can't, it's longer than my fingers, and I got to put a 8-pound baby through, it's a good thing, okay? So if it says diagonal conjugate not reached, it means it's wider or longer. The opening is enlarged, which is a good thing, okay? But again, the smallest part that the baby has to get through is estimated off of the diagonal conjugate. And again, what's the need to know? We usually want it in double digits. Because again, diagonal conjugate somewhere around 12.5 or so. We subtract 1.5 from that. So as long as that is in double digits, I'm usually pretty good in terms of the outlet the baby needs to come through, okay? We do not measure that as registered nurses. That's not our job. And if you really want to be precise, it has to be done by x-ray. We don't want to do x-rays with people who are newly pregnant because x-ray hurts the baby. So on to the breast. Again, the breasts change going through puberty. Again, we talk about the characteristics of puberty. So you start to see growth of underarm hair, you start to see bud development. The breasts, when they start going through that change, may be painful. It's not uncommon for young women to experience that. Generally with the breasts, what you will see, notice that the structure, we have a lot of glands underneath the breast, okay? So it's not just one thing that causes the production of milk. In some women, when they are very early pregnant, because of the hormones that are released in early pregnancy, they actually will have a little bit of leaking of colostrum, okay? That is normal, that's expected. But if you don't leak colostrum, that's also normal. It doesn't mean you can't breastfeed or anything like that. As a nurse, if I'm getting a history from a patient, I certainly would want to know if they've had any kind of breast surgery, whether that was breast reconstruction, augmentation, or breast reduction surgery, because that may influence whether or not the patient is able to successfully breastfeed. Okay? And so what will happen is, as the baby latches on, the baby will compress those ducts, and the milk will actually come, and it's like a bunch of little droplets together that will form the milk that comes out of the breast. And again, there's kind of multiple processes that have to occur to have the letdown. So you make milk, but you also have to have the letdown reflex to eject the milk. And we'll talk about that when we get into breastfeeding. So you want to look at the breast, you want to look at the areola and the nipple. Some women have very large nipples, okay? We want to make sure that the nipple should be everted. It should not be inverted. If it's inverted, meaning it turns in, it's harder. There's not much there for the baby to grab onto for breastfeeding. So for those women, we can sometimes do some exercises during pregnancy, as long as there's no complications, to try and evert the nipple. The other thing is they might do a breast shield or something like that to help the mom breastfeed. The other thing about breasts, I will never ever forget this. So some folks are like, I don't ever want to do a breast exam on a pregnant woman. Why would you ever do that? Believe it or not, this is an opportunity. Women are in healthcare. It's a great time to do a breast exam to see if there's anything abnormal there. I will never forget the OB. Everybody used to make fun of her, but sure enough, she detected an abnormal mass on a postpartum mom. It was not related to breastfeeding. It was cancer. So this mom with this brand new baby, she had stage 3 breast cancer. And because of this doctor, they operated on her right away. They started her on chemo, and she came back and saw us. And it was she had no hair, but was holding her little baby. And she lived because somebody thought to check her breasts. And I know there's all this stuff about breast exams, and they're not predictive. I totally get that. But I do think women kind of need to know their breasts. If something doesn't look right, something hurts, something's leaking that shouldn't be leaking, there should not be any discharge from the breast if you're not pregnant or lactating. So if you are not pregnant and you have white, again, it may just be a hormone imbalance, but it could be something else as well. All right, I need you to take a deep breath. Keep this simple, okay? Keep it simple. So we have 2 ovarian cycles. They occur at the same time as the uterine cycles. The nice thing about the ovarian cycles is they match up with the name of the hormone. So you have the follicular phase and the luteal phase. They are divided by ovulation. So in the follicular phase, the primary hormone happens to be FSH, which is follicle stimulating hormone. In the luteal phase, the primary hormone happens to be the luteal hormone. So it's very easy, okay? Now, what happens here in the ovarian phase, under the, again, FSH, you have the maturation of the follicle. And so you progress from this follicle, and this is, again, an important structure, the Graafian follicle. Why is it important? Because after ovulation, that's going to become this corpus luteum. The corpus luteum produces progesterone. Let me say that one more time. The Graafian follicle is going to become the corpus luteum. The corpus luteum produces progesterone. Okay, that's a hormone. Now, there's no fertilization here, and remember, we're not fertilizing the corpus luteum. You're fertilizing the ovum. So no pregnancy, the corpus luteum degenerates. Now, ovulation should happen mid-cycle. So in other words, if I tell you I have a 28-day cycle, then I'm probably going to ovulate somewhere around day 14. If I have a 30-day cycle, I'm ovulating somewhere around day 15. So again, we base things off 28-day cycles. That's kind of more classic. But if you talk with a lot of women, sometimes it's 27 days, 28 days, 32 days, 34 days. Those are people who have a really hard time with family planning because their cycles are all over the place. And again, sometimes you know you ovulate and sometimes you don't know you ovulate. Now, for some women, when they ovulate, what will happen is the cervical mucus changes. And so what this does, it gets kind of slippery and thin and gray. And then, gosh, what's the name of it? Middle smirts happens. And that what happens with that is women have a little bit of pelvic pain with that. Some women, when you have the rupture of the follicle and the release of the ovum, they have a little bit of pelvic pain and they have a little bit of bleeding. And that's why women think, oh, that was my period. And that's how people who have a period end up pregnant. It wasn't their period. It was the rupture of this follicle with a little bit of pain. Okay? So the idea of, can I get pregnant on my period? Well, if it truly is your period, more than likely not. Okay? If you are a textbook cyclical person. If you're not, and your cycles are all over the place, then that may not actually be your period. Now, with the cervical mucus, the other thing, a very slight temperature change when you ovulate. And so that's one of the reasons why when people are doing natural family planning, they're trying to have a baby, they're going to look for that gentle uptick. It's like a half a degree or so in the morning of their temperature. And that gives you a sign that you're ovulating. You notice a change in your cervical mucus. The cervical mucus is designed to help the sperm meet the ova. Okay? So it's like, pa-chow! Because again, millions of sperm need to try and be the one that meets the ova, and hopefully they go the right direction. Because sometimes they take a right, and sometimes they take a left, and you don't know which side released the ovum. Okay? So again, this is normal. It does not itch, it does not burn, it's not white, it's not creamy, it doesn't smell funky. It's very normal, expected. This is ovarian. All right, at the same time, we have uterine phases. You will leave here today wondering, how in the world do people get pregnant? It happens all the time. It's really not this complicated, okay? It's nice that we don't have to think about this stuff. It just happens on its own. So there are 4 uterine phases: menstrual, proliferative, secretory, and ischemic. Okay? There are 2 ovarian phases, there we go. Follicular and luteal. Now, notice that during the menstrual cycle, menstrual phase, that's when women have vaginal bleeding. They're shedding that uterine lining. And so you can see here, the lining is very low, very thin. Now, during the proliferative phase, remember, what FSH was kind of kicked into gear here, okay? But I've gotten the follicle ready to go. FSH is going to decline. Estrogen is going to increase. Estrogen is needed to help get that uterine lining getting ready. It's kind of like a catcher at a baseball game. Okay, I'm ready. Is there pregnancy? What happens kind of right here in the middle is ovulation. Now, after ovulation, remember that we have the uterine lining still very, very important, waiting to see if there's a fertilized ovum. This gets even thicker and richer in response to progesterone produced by the corpus luteum. Now, notice again where we are in terms of days. So we're talking about days 14 through 22, okay? Optimal time, again, usually again with ovulation, you have about a 24-hour window to get pregnant. Now sperm live 3 days or so, but really the ova has about a good 24-hour window. Now, hopefully
hopefully, if I wanted to get pregnant, I had fertilization, and I am now buried in to this uterine lining. If I'm not pregnant, hormones decline, and I get into the ischemic phase. What do you remember about ischemia from med-surg? You've heard that term before.
Yeah. What's that? Loss of blood flow. It hurts. That's what causes kind of premenstrual type pain. When people start feeling crampy and achy, they're going through that ischemic phase, and then when they start shedding the lining, that's when their period starts. That's when the patient's period starts. So again, looking at, we have menstrual, proliferative, secretory, and ischemic. Halfway through the cycle, mid-cycle, ovulation should occur, okay? From ovulation, what happens is, very early, we have FSH. FSH matures the follicle. So FSH is very important here, okay? Now, as I start to increase this uterine layer, estrogen is increasing. When estrogen increases, FSH decreases. So then you have the rupture of the follicle, which releases an ova to be fertilized, and that's ovulation. So right here during menstrual phase, okay, FSH is maturing the follicle. It's nurturing it, getting it ready. So as you get through that kind of first week or so, then what happens is the uterine lining needs to enlarge. Estrogen engorges things, it vasodilates things. As estrogen increases, FSH decreases. So again, in response to that, you have ovulation. After you ovulate, progesterone is an important player because progesterone is going to make that uterine lining, it's going to make the apartment for the potential blastocyst. Okay? It's like, I'm ready, we're good, it's all good to live here, 3 bedrooms, no waiting. And then if there's not fertilization, the hormones decline, all those vessels shrivel up, you start to have some muscle contraction that contributes to pain in the ischemic phase, and then you shed the uterine lining. So what I would suggest is you need to know the ovarian phases, you need to know the uterine phases, and you want to think about which hormone is really a player and which phase, okay? So the reason why these are blue is to cue you in that this FSH tends to happen primarily here, but it's an ovarian. FSH doesn't do anything for the uterus. FSH is for the follicular phase, but it just happens to be concurrent with the uterine phase of the menstrual cycle, okay? In terms of the proliferative phase, FSH is going to decrease. Estrogen is going to increase. We have what's called a surge of LH that contributes to ovulation, which occurs in the middle between menstrual and proliferative. It also occurs between the middle of what and what in the ovary? Follicular and luteal. Okay? So the surge of LH is critical for ovulation. And that's why some women who have difficulty ovulating, it may be that their LH levels are not high enough. Progesterone. We talk a lot about progesterone. We're seeing more and more women get supplementation with progesterone who are at risk of early pregnancy loss. Progesterone is pro-pregnancy. It makes the environment ready for a baby. And progesterone is really important in the secretory phase. Both your hormones are high. Estrogen and progesterone are high because, again, if you get pregnant, they stay high. If you don't get pregnant, they decline and you go into the ischemic phase. Okay? All right, so you can see hormones, I would definitely kind of quiz yourself on hormones. but keep it simple. And the other thing is, I want you to think about how you would talk to a patient about when she would want to get pregnant, when, if she doesn't want to get pregnant, when should she have intercourse, not have intercourse, what's going on with her hormones, what's normal and what's expected, okay? So again, under FSH, that's going to help that follicle mature, okay? And so it's part of the pituitary gland. So if you have someone who has some type of pituitary dysfunction, their FSH levels may be off. So if somebody's not ovulating, that may be one of the labs that they look at. There's actually a lot of hormones that come from the pituitary gland that affect reproduction, pregnancy, and childbirth. Now with LH has to happen. There's a big surge, a big spike, and that leads to ovulation. Other symptoms that occur with ovulation, we have a change in the cervical mucus and a very slight change in temperature. So if you have somebody who wants to, again, know when they're ovulating, they want to check their temperature first thing in the morning. We usually have them do it every day for several weeks. And again, we're only looking at maybe a half a degree or a degree change. So it's not a fever. You're not going from 98 to 101. You're going from 98 to 98.5 or 98.5 to 99.5. It's very subtle. So that's why any type of activity will cause that fluctuation. Now you have to remember there's also different kits that you can buy over the counter that predict ovulation. And again, they're looking at different hormones that are present in your urine. If you get a blood test or things to check that to accurately predict when you ovulate. All right, estrogen. Estrogen is critical. With estrogen contributes to the development of the female reproductive organs, so breast enlargement. Estrogen causes vasodilation. It's one of the things that as women go through menopause, you have a decrease in estrogen. So that's when we start to see the development of clots in women as they get to their 40s and 50s. We start to see osteoporosis develop, and again, it's because of that decline in estrogen. With estrogen, estrogen is needed to also help in terms of the maturation of the follicle. But remember, when estrogen's increasing, FSH is decreasing. Now, I will tell you, FSH is not a critical player in pregnancy. Why? Well, because it has no job. Because its job is to develop a follicle, okay? So we don't look at FSH levels in pregnancy. We really don't even look at estrogen levels. But I will tell you with estrogen causes vasodilation, so it causes things to be edematous, vascular, and that's one of the, again, we need that in pregnancy because not only do you need to provide circulation to yourself, but another person. Progesterone. So students get mixed up between prostaglandins and progesterone because they sound alike. Prostaglandins are not bad things, okay? You need some prostaglandins, but progesterone inhibits muscle contraction. Prostaglandins cause muscle contraction, okay? So prostaglandins are needed because once fertilization occurs in the outer third of the fallopian tube, we need it to move, okay? So sperm have prostaglandins. The fallopian tube, there'll be, again, when fertilization takes place, prostaglandins help move the little zygote into a morula, into a blastocyst, so it gets inside the uterus, okay? But progesterone helps in terms of making sure you maintain the apartment for the baby, okay? You maintain the uterine lining. It also helps you smooth muscle relaxation. The uterus is a big giant muscle, but it's not choosy. So in other words, not only does it relax the uterus, it also relaxes all the GI muscles. So then you have decreased GI motility. Okay, it's an all or nothing kind of thing. With progesterone, again, that's the hormone of pregnancy. We want that to be high. It stays high the whole pregnancy. One of the theories about what starts labor is a drop in progesterone. So again, I don't want you to think prostaglandin is bad, but there are some medications that cause the production of prostaglandins. or create synthesized prostaglandins, and those would be things that we would not want to give during pregnancy. So for example, misoprostol, which you know as Cytotec. Cytotec is a medication that causes contractions, and it has to do with prostaglandins, okay? All right, so in terms of the male reproductive system, again, we want to make sure that men have a longer lifespan in terms of reproductive. So men can still produce sperm, they can have a baby late in life. Women, again, the cycle in which they're able to have children varies slightly, but in general, the average age for menopause right now is close to around 50, okay? Whereas men, again, have a much longer reproductive cycle. So you have the production of sperm. Sperm will come through and leave the penis. Again, millions of sperm are produced here. In terms of if the patient has a vasectomy, we usually will, again, trim this here. So you make a cut here so that sperm are not connecting through and ejaculated through the penis. In terms of male reproduction, one of the things that you want to ask your patient about, we talk a lot about erectile dysfunction. As men get older, if they have hypertension or any type of vascular disease, they sometimes have difficulty with ejaculation. And so we have to look at maintaining kind of normal health habits for both men and women. You would want to make sure they're avoiding alcohol, drugs. We want to make sure they have good folic acid intake. But I think the other key thing to remember is that sperm can fertilize the ovum. They usually have about a 3-day window. So you'll have some patients who are very adamant, like, I know exactly the day I got pregnant. It's like, well, approximately, okay? Now, it doesn't make a big difference to us if the baby's due December 24th or December 25th. You know, we're a little bit more fussy if there's weeks difference. But the other thing you gotta remember is sometimes if somebody's had multiple partners, we don't know who the father is. And so sometimes we need to look at when sexual activity occurred, and then we need to look at paternity testing, genetic testing, looking at family history to see what type of birth defects may be on which side of the family. Okay. Now, most OBs do not talk about male reproduction at all. Usually it's urologists who talk with men about male reproductive. I do feel like there's a movement toward family planning and family contraceptive care and looking at couples counseling, because I think you want to be kind of joint in your decision about choosing whether or not to have a baby and what type of contraceptive to occur. I just haven't seen it in this area. We tend to be pretty conservative, pretty traditional here in Louisville in regards to childbearing. All right, I got about 15 minutes, so let's go ahead and trudge on to conception. Now, with conception and fetal development, if you have a background in biology, biochemistry, genetics, this is incredibly fascinating. I think there's a tremendous opportunity for nursing in genetics. There's genetic counseling programs. Some of our healthcare providers here in this area, we have genetic counselors not just for OB, but also for our cardiac patients and particularly our oncology patients. And it's because, again, we're looking at the genetic makeup of tumors, making sure that the medications that the patient's taking are appropriate for the type of cancer the patient has. So this is very superficial. I do think the PowerPoint guides you into what you need to know about this section. So I would recommend sticking hard to the PowerPoint and not getting bogged down in the book. There's a lot more details in the chapter. Okay. So again, we're going to review, and you probably had this at some point, so it's just refreshing it in your memory in terms of the processes with fertilization and early pregnancy development. We're going to talk about key structures because those are often important and can influence risks for pregnancy and childbirth. We'll talk just a little bit about genetic conditions. We probably will not get to that today. And then talk about how to talk to patients in regards to having a healthy pregnancy. So just some review. You do not need to remember all your different phases between mitosis and meiosis, okay? With mitosis, remember that you end up with the division of cells and they look like each other, whereas meiosis, that will carry the sex characteristics. In terms of the female, okay, this kind of shows you, notice that you have the ovum, this polar body, that's the corpus luteum, but I only carry an X if I'm female and I have an ovum, versus males with sperm. In terms of the division, you have 4 opportunities to conceive. Women only have 1 opportunity to conceive. So again, you can see here with each one of these sperm cells, it's either an X or a Y. So why is that important? It's the male who determines the gender of the baby, okay? So a woman always has an X. So if the sperm is an X, you have an XX, which is a girl. If the sperm contributes a Y, it's an XY, which is a boy. Now, sometimes what can happen is there's some abnormal replication. There might be a missing chromosome, there might be an extra chromosome, and that contributes to genetic defects, okay? So what happens in terms of fertilization? So you have ejaculation of sperm. So again, millions of sperm have traveled. Some will not make the journey. The environment, it's too far, they get distracted, they're kind of not meeting in the right place. Some are not strong enough. Some are slow, they won't make it in time. And so as you get closer and closer, again, they will attack the ovum. Now, some things need to happen to the sperm before it tries to, again, impregnate the ovum. So you have this acrosomial reaction. Basically, it's a shedding of the head of the sperm to be able to penetrate the zona pellucida, which is, again, it looks like sun. It's kind of radiating. The choriana radiata is also part of this, okay? Now, what happens is as soon as one sperm gets past here, you have the cortical reaction. So the acrosomial reaction is first. The cortical reaction closes the door. It says, no more sperm can get through. And that's when fertilization occurs. And again, you have the rapid division and multiplication of cells. Now, from this, again, parts of these structures will then turn into other things. But at this point, the patient has no idea that she is pregnant. Okay, there's nothing there that will say, so you can't take a test, you can't do anything that says, yep, fertilization took place, I know it worked. And again, this is occurring in the fallopian tube. This is occurring in the fallopian tube. Now, this should be happening mid-cycle. So if I said if the patient told me that her last menstrual period was October 1st and she wants to get pregnant and she has 28-day cycles, then I would advise her to have intercourse around October 15th, okay? Again, if I were the nurse doing client education, I would probably go a little bit early rather than a little bit later. Because again, I'm thinking about that window, so 14, 15 would be better than 16, 17, 18. Fertilization takes place, and again, prostaglandins are helping things move along here so that eventually what will happen is the blastocyst will burrow inside the uterus. What's happening all during this time, all those hormones, estrogen, progesterone, high. They do not decline. Since there's no decline in hormones, there's no shedding of the uterine lining, you miss a period, you think you're pregnant. Now, during this time, usually within a couple days after fertilization, the embryo is producing early pregnancy factor, EPF, okay? So EPF is a signal to the body of, don't reject me, this is not something I need to be alarmed about. But the newer pregnancy tests that tell you that you're pregnant sooner, they're detecting early pregnancy factor rather than beta HCG, which is kind of the classic hormone that we looked for in the presence of pregnancy, okay? Here's the thing, lots of things can happen between here and here. So I think in some ways it's good to know that you're early pregnant so that you don't engage in risk behaviors. You stop smoking weed, you stop drinking alcohol, you get plenty of sleep, you take a prenatal vitamin. But also I think it's not the time to go buy baby clothes because a lot of women have miscarriage during this time. Some women will become pregnant and lose the pregnancy and never know it. They just have a heavier period that time and they don't think anything at all about it. They had no idea that they were ever pregnant. So I think again, when you're talking with women and they talk about their periods and they'll say things like, gosh, it was so painful at all. I passed this gigantic clot. We might want to investigate that further and make sure that there's nothing abnormal there. The other thing you got to remember is not only do pregnancies make hormones, but tumors make hormones. And so there may be a tumor or a mass that is producing beta HCG that is causing the positive pregnancy test. We'll stop here and pick up on Thursday.